In today's session at Medical Sciences, we are going to take you through heart failure. We are going to look at the symptoms of heart failure. We are going to look at the types, then the pathophysiology behind it, then the diagnosis of heart failure. And as we begin, we always urge you, if this is your first time, to go to the subscription button, then subscribe, like the video, and share to many others, that we may continue to serve you and you're always notified whenever we release new videos. So what is heart failure? Heart failure, this is a complex or chronic progressive inability of the heart to supply or to meet the body's demand. So when the heart is not able to pump blood that meets the body's demand by supplying all the organs in the body. So that inability of the heart, it does not mean that the heart has stopped working completely. It is still working, but it is unable to supply the body's demand. So inability of the heart to meet body's demand is what we are calling heart failure. And this heart failure is characterized by many signs and symptoms, whereby among the signs and symptoms, how do you know that someone is developing heart failure? And one of the signs is fatigue. You find someone has fatigue and muscle weakness, is very weak, fatigue and weakness. People may develop shortness of breath. You find it is hard, it is becoming hard to breathe, and that term is known as dyspnea, which we call shortness of breath. That is another sign. Then it can continue and we can have palpitations. Palpitations is feeling your heart beating when at rest. Then we can also have what we call edema. And this edema, which we call swelling, this is swelling of the limbs. That can be the feet, the ankle at the knee, and many other places, especially the extremities, that is the feet or the lower parts of the legs. And sometimes it can even go, it can be peripheral edema, whereby all parts, including stomach swelling, including the face, it can also reach there. That is what we are calling swelling. That is termed as edema. It can be both the shortness of breath, which we are calling dyspnea, is due to pulmonary edema. Then it can also occur on all parts of the body, including the lower extremities, including the face and the stomach, due to some organ damage. So these are some of the signs and symptoms which you can use to suspect someone with heart failure. Then what are the causes? You can ask yourself that what can be the causes? What can cause heart failure? And this heart failure can be caused by many factors, including one can be myocardial infarction. Myocardial infarction is due to blockage of the coronary arteries that supply the myocardium or the muscles of the heart. So if someone had a myocardial infarction, which we locally know as heart attack, this is known as a heart attack. It can also lead to heart failure. Then people with cardiomyopathy is due to lack of enough oxygen supply to the muscles of the heart. It can result into muscle damage of the cardiac muscles, which we are terming as cardiomyopathy, which can lead to heart failure. Another condition, it can be coronary artery disease due to the blockage of the arteries supplying the myocardium. And another cause of heart failure can be hypertension. Hypertension can also lead to heart failure. Then other causes can be myocarditis. Myocarditis, that is inflammation of the cardiac muscles. So when the cardiac muscles get inflamed, it can result into what we call heart failure. Then another one can be due to failure of the valves to close, which we call valvular stenosis. Whereby the valves, they are failing to close completely. It can also result into heart failure. So these are some of the causes which can lead to the heart failing to supply body's need, which we are terming as heart failure. And what is the pathogenesis, or how do you know that how do these complications develop? How do these complications develop? And the pathogenesis, we are looking at the pathophysiology, or how do this condition, or how does heart failure progress? But before we reach how it progresses, we are going to see it is categorized in two types, whereby the types include, there is one which is known as systolic heart failure. Then the second one is diastolic heart failure. Systolic heart failure can also be termed as heart failure due to reduced ejection fraction, whereas diastolic can also be heart failure due to, so the ejection volume under diastolic is normal. Here the ejection volume reduces by less than or equal to 40%, whereas with diastolic, the ejection volume is normal. It is greater or equal to 50%. So here there is normal ejection under diastolic, whereas under systolic there is reduced ejection volume. So these are the two types. And how does systolic heart failure comes about? This one is majorly due to decreased cardiac output. So this one leads into, because if the ejection fraction, that is the amount of blood ejected per beat, decreases, it also leads to decrease in cardiac output. So cardiac output decreases. Whereas in diastolic, so we are seeing that this decrease in cardiac output is due to the failure of the left ventricles. Here the left ventricles are failing to eject all the blood that comes in. So they are defying what we call Starling's law, Frank Starling's law, which says that the amount of the blood which comes back to the heart is the same as the amount of blood pumped out at the end of contraction or systole. So this one, we are seeing that the left ventricles, they fail to contract adequately so that it can eject all the blood that comes in during relaxation, which leads to decrease in cardiac output due to decrease in stroke volume. Then with diastolic heart failure, this is the failure. It is due to the ventricles failing to relax completely. Then when the ventricles during diastole fail to relax completely, the amount of blood that is filled within the ventricles reduces. So this one leads to reduced preload. So this one is characterized by decrease in preload, and it is due to the failure of the ventricles to stretch. The ventricles lose their stretchability, and then which impairs the feeling. And when little blood comes in, little is ejected. So this is how we can categorize them into two. That is systolic heart failure and diastolic. Systolic due to the failure of ventricles to contract to eject our blood, then diastolic due to failure of the ventricles to relax completely. It can be due to hypertrophy of the left ventricle, so that little blood is filled in during relaxation, which also affects the activity of the heart. So after looking at these two types, now we can look at how do they develop. And after developing, how does the body shape itself to compensate for these two types? So we have seen that for type systolic heart failure, there is reduced ejection fraction leading to decrease in cardiac output. And when cardiac output decreases, there is a decrease in the perfusion of the organs in the body. So we are going to see the compensatory mechanisms. What are the compensatory mechanisms that comes in to restore either systolic heart failure or diastolic heart failure? So we have been looking at the types and how they come about, which we know as pathophysiology. Now we want to look at the compensatory mechanisms. So the compensatory mechanisms so when there is increase in cardiac output, when there is a decrease, especially during systolic heart failure. During systolic heart failure, there is decrease in cardiac output, which leads to decrease in the perfusion of organs. So what happens? Then we are seeing diastolic heart failure leading to decrease in preload. And all this one results into decrease in the blood pressure, because we know blood pressure is equal to cardiac output times stroke volume times heart rate. So decrease in the pressure. If we have the heart, this is a simple drawing of the heart. Having the pulmonary artery, having the aorta, then the pulmonary, and then we have the vena cava being supplied by So after seeing this, when there is a decrease in blood pressure, the body is going to compensate this decrease. And how does it compensate? There is in the aortic arch and the carotid artery, there is what we call the baroreceptors. And these baroreceptors are going to detect decrease in blood pressure. And this detection decrease in blood pressure is going to compensate by increasing sympathetic activity. It's going to increase sympathetic stimulation. At the same time, it's going to stimulate or increase RAS system. At the same time, the body can compensate by causing what we call myocardial hypertrophy. This is the three mechanisms how our body can compensate this decrease in cardiac output due to heart failure. So this is undercompensated heart failure. So this one we are looking at it as compensated heart failure. And undercompensated heart failure, that when it happens, the body has the adaptive nature, how it can cope up with the decrease in cardiac output and decrease in preload. How by stimulating the sympathetic outflow, stimulating the RAS, and stimulating the myocardial hypertrophy in order to increase again the blood pressure and blood pumping so that we can meet the body's demand. So we are saying with the sympathetic that when there is a decrease in pressure, the baroreceptors detect and send impulses to the cardiovascular center within the medulla, within the medulla. And this cardiovascular center within the medulla, after sending impulses, it is going to come and release norepinephrine both to the sun, to the AVN, and the myocardium. So we are seeing it is going to supply the norepinephrine to the sun, conductive parts of the heart, together with the myocardium of the heart. And remember, within the heart, we have what we call the beta receptors, whereby there is beta 1 receptors in the sun, SA node, and AVN, together with the beta 1 in the myocardium. Then at the same time, we also have alpha 1 receptors. So it is also going to supply to the blood vessels. And within the blood vessels, we have receptors, which we call alpha 1 receptors. And all these, once the cardiovascular center in the medulla oblongata is stimulated, it is going to increase the release of norepinephrine, the alpha 1 receptors in the blood vessels, that is both the arteries and veins. Then it is going to increase production of norepinephrine in the beta 1 receptors. And increase in the production of norepinephrine, it is going to increase sympathetic activity. One, it is going to increase contractility. It increases heart contractility, then increases conduction. This one results into increase in heart rate, and as a result, we shall see increase in cardiac output. And how does it do it? Is by increasing intracellular calcium ions. When calcium ions increase within the myocardium, it is going to increase contractility. And by increasing conduction, it results into increase in cardiac output. And our problem was decrease in cardiac output. So it has adapted by solving the problem of decrease in cardiac output by stimulating beta 1 receptors in the heart, leading to increase in contractility, conduction, and heart rate, which results again into increase in cardiac output. And we can see that increase in cardiac output will result into increased perfusion, which will meet the body's need. Then another thing, its action on the alpha 1 receptors in the blood vessels, it is going to trigger what we call vasoconstriction. Vasoconstriction. And when there is increased contraction, constriction of the blood vessels by decreasing in their size, it is going to increase systemic vascular resistance. And when systemic vascular resistance increases, it leads to increase in afterload. So when we increase afterload, so both increase in the systemic vascular resistance, increase in the cardiac output results into increase in afterload. It results into increase in the afterload. That is what we can see. So that is via alpha 1 receptors being stimulated by the sympathetic outflow. At the same time, if we have the kidneys containing the kidney nephron. So the kidney nephron contains what we call juxtaglomerular cells. And these juxtaglomerular cells in the kidney, nephron contains also what we call beta-1 receptors. And these beta-1 receptors can be stimulated by norepinephrine to secrete renin. And this renin is also responsible for converting a liver protein known as angiotensinogen to angiotensin 1. And this one is stimulated by renin due to stimulation of beta-1 receptors by norepinephrine. At the end, we're going to see this angiotensin 1 being converted to angiotensin 2 by an enzyme from the lungs. Lungs produce enzyme known as angiotensin converting enzyme. These are found in the lungs, which convert angiotensin 1 to angiotensin 2. And this angiotensin 2 has different receptors in the body, whereby one, it can go to the blood vessels, that is the veins and arteries. Another one, it goes to the adrenal medulla, adrenal cortex. And another site, it goes to the posterior pituitary gland. Here it causes production of antidiuretic hormone. Then on the adrenal cortex, it causes release of aldosterone hormone. And here it causes vasoconstriction. So vasoconstriction leads to increase in afterload, whereas aldosterone is going to cause increased sodium and water retention. So more sodium and water is reabsorbed, and this one leads to increase in blood volume. So blood volume in the body increases, and increase in the blood volume increases preload. This one increases preload. Together with ADH, still ADH causes increased reabsorption of water. So this one leads to increase in the blood volume, and this increase in the blood volume increases preload. And sometimes this one, when too much blood is retained, it is the one that can result into what we call edema. So this one, if more blood is retained, which increases venous return, it can result into pulmonary and systemic edema. How? Due to increase in hydrostatic pressure. Because if this blood increases the pressure, it leads to the leakage of the blood into the interstitium, leading to swelling, which we call edema. So this is what we can see as a compensatory mechanism, that is RAS. So RAS is either stimulated by the sympathetic activity or stimulated by decrease in perfusion, or even decrease in sodium retention. So when there is increased secretion of sodium and chloride or decrease in perfusion, still they stimulate the juxtaglomerular apparatus, which causes the RAS into play. So after we have seen this, another compensatory mechanism is that as the preload increases, the cardiac output increases, the heart muscles are also going to adapt by increasing in the size in order to overcome the pressure which has been increased on them. And this is what we are calling myocardial hypertrophy, especially left ventricular hypertrophy. It is increasing in size in order to overcome the increased preload and to overcome the increased afterload. So which leads to the increase in the size of the left ventricle myocardiums. So this is what we can discuss in this session, and we can end it by looking at the diagnosis. How can you diagnose heart failure? One of the tests we can do is chest X-ray. We can do ECG and echocardiogram. ECG, we are looking at the left ventricle hypertrophy. We are looking at the possibilities of the myocardial infarction. We can even go ahead and we order even for cardiac markers, especially the CK-MB, which can rule out myocardial infarction. We can also do, because we are seeing increased preload is going to cause increase in stretching of the cardiac muscles, and increasing in stretch will lead to production of BNP. That is a B-type natriuretic peptide, and then the atrium will secrete ANP. That is natriuretic peptide. And these peptides, BNP and ANP, also causes increased sodium secretion. So we can also in the lab determine levels of ANP and BNP, these vasoactive substances, which can also be a good marker for diagnosis of heart failure. So this is what we can discuss with you. I've looked at the signs and symptoms, the causes, then the pathophysiology, both the systolic and diastolic, how it comes about, and how does the body compensate by increasing sympathetic outflow, increasing the RAS activity, and increasing the myocardium size. How we have seen how they come about, both increasing cardiac output and systemic vesicular resistance, which leads to increase in afterload, which can increase cardiac output. Then we are able to meet body's demand. Another thing we have seen either decrease in the perfusion or increase the sympathetic outflow to the juxtaglomerular cells in the kidney, leading to release of renin, which leads to production of angiotensin II, which can cause vasoconstriction, increasing both afterload and preload, production of aldosterone and ADH, which increase sodium and water retention, increasing blood volume, which can result even into edema and low left ventricular hypertrophy. So in the coming video, we are going to look at which drugs can we use to target these systems so that we can treat the problem of heart failure. Thank you so much for learning with us at Medical Sciences, and may God, Lord, bless you.